Can you see my screen on my slides? Good. Okay, so definitely this will be not only auscultation. We'll talk about patient symptoms and other signs. We need to start with dyspnea or breathlessness. And I think, first of all, well, the first question will be for you is how to describe or how to classify a dyspnea in a patient. From the point of view of etiology, dyspnea may be associated to respiratory or cardiac disease. But point is that, first of all, we need to describe it according to what patient is presenting to us. How that can be done? What are the basic subtypes of dyspnea? Any ideas? Doctors, it's not the lecture, it's just class. Well, any ideas? Any options? Any well, guesses may be correct. So don't be silent. Try to discuss. Can you hear me now? Good. Okay. So first of all, the most common type of dyspnea that may be present in respiratory diseases and cardiac diseases is tachypnea, rapid breathing. So therefore, there may be just more intensive ventilation of alveoli that may be seen, first of all, in the case of congestion when there will be just higher pressure and a slower velocity of blood flow around alveoli. And it's typical for restrictive respiratory diseases. So let's say if patient will have a very stiff rib cage, if patient is an elderly person, if patient will have severe pulmonary fibrosis, if a part of the pulmonary parenchyma will be affected by some consolidation disease like pneumonia, in that case, patient will have tachypnea as the result of inability to ventilate normally lungs at tidal breathing, and definitely deeper breathing will be more complicated. That's first, and the basic. Tachypnea as well is a variant of physiological dyspnea in the healthy patient at the physical load. Second is difficulty in breathing in or breathing out. Difficulty in breathing out is quite specific. Expiratory dyspnea, difficulty in breathing out, is typical for obstructive diseases. That will be the bronchial asthma, that will be the COPD, chronic obstructive pulmonary disease, like obstructive bronchitis or emphysema. In that case, air will be trapped in an alveoli. It will be difficult to push, to expel the air out. So that will be the expiratory dyspnea. Inspiratory dyspnea, again, is typical for restrictive disease. If the chest will be too tight, if a sclerosing of rib cage, if fibrosis of the lungs will be extremely severe, in that case, patient obviously will notice that it's difficult to breathe in. Moreover, that will be also verified by patient examination, physical exam, or pulmonary function testing. Sometimes patient may have mixed disorder. For instance, let's say patient is having emphysema and pulmonary fibrosis. In that case, there will be both combination of difficulty to breathe in and breathe out. Less type of dyspnea is just, well, something in patient's mind when patient will just feel some kind of, well, air hunger, feel that there is not enough air, but the mechanics of patients' ventilation that will be evaluated by, again, physical examination, that may be verified by spirometry and spirography, will be absolutely normal. That is a so-called functional disorder, rather psychosomatic disease than the actual disease of patients' heart or lungs. That'll do, and that is important for our examination. Good. Second is coughing. That may be either dry, it may be associated to irritation or bronchial mucosa, most commonly. Anyhow, sometimes dry coughing may be related to irritation of pleura. And coughing may be productive. Coughing may be associated to expectoration of sputum. That also is quite important from the point of view of assessment of patient's diagnosis. So if a patient will have sputum, what do we need to pay attention to? If it will be mucoid, so pure mucus, mucus actually is the normal result of the functioning of bronchial epithelium. And it means that there is just exaggeration of normal response of normal function of goblet cells in bronchial mucosa. It may be due to which disease. Definitely, most likely, most commonly, will be seen in obstructive diseases like asthma. That is the classical disease that will result in a purely mucoid mucus sputum. Anyhow, there may be some exceptions, some not as typical cases that you need also to keep in your mind. It may be tumor, it may be bronchogenic cancer, that will in the first stages will grow into the lumen of bronchus and slightly irritate, not destroy, but just will cause some kind of abnormal airflow through certain portion of bronchial tree. In the early stage of cancer, patient will have no blood streaks. In the sputum, it will be just mucoid. So it will be well, absolutely inspecific, but please remember that it may be due to pulmonary cancer. TBC, again, it's not typical for TBC. It's not helpful, but again, you should keep in mind that it may be the result of mild affection of pulmonary parenchyma or bronchial tree by Mycobacterium tuberculosis. Emphysema, even less common. Emphysema by itself is not the cause for mucoid sputum, but if emphysema will result in obstruction, if emphysema will result in compression of bronchial system, and if we consider emphysema as the variant of etiology of COPD, sorry. In that case, yes, emphysema may cause development of mucoid sputum. Same is true for pneumonia. Mild issues, mild disorders in patients with focal pneumonia or the very onset of lobar pneumonia may result in mucoid sputum. Mucopurulent is not pure type of sputum. It's a mixture of mucoids, that is the over-secretion of bronchial epithelium and presence of pus means that there is severe exudation into the bronchial lumen and destruction of WBCs, of leukocytes, in the mucosa, in the mucous layer, or into the lumen of bronchus. It also may be seen in basically same diseases, but point is that there should be some kind of complication of that. So it may be bronchial asthma complicated by acute bronchitis. It may be tumor that is inflamed. It may be mixture of specific flora to inspecific in patients with tuberculosis and so on. Typically, purulent sputum will be seen in patients with severe chronic bronchitis and sometimes in the mild stage of destructive diseases like bronchiectasis or remission or the just mild cause of lung abscess. If it will be rusty, rust-colored and purulent, that's typical for classical lobar pneumonia. At the onset of the consolidation stage of pneumococcal pneumonia, it will be just rusty. It will be some dark red color. Then with progression from the consolidation stage to resolution stage, it will be already not as rusty, but it will become purulent. So again, it may become inspecific, and therefore, if you'll not ask patient about what happened previously, if you'll not ask patient about what about the color of the sputum a couple of days, maybe a week ago, you'll have no chance to detect that's typical rusty sputum. And again, it's a very nice and reliable hint for classical lobar pneumonia presentation. Red currant jelly. Red currant jelly is severe destruction of capillaries around affected alveoli. It may be seen in patients with the severe type of lobar pneumonia, that's pneumonia caused by Klebsiella. Again, it's not constant. Typically, patient expectorate the sputum just for one, maybe a couple of days. Then again, it will become rather purulent than blood-stained. Fall odor. Fall odor means that patients have a gram-negative flora that gives extremely unpleasant smell from patient's sputum, from patient's mouth, as patient is breathing. And it means that you should expect more severe disease. It means that it's not just, let's say, pneumonia, but it's pneumonia that may have a risk or already complicated by bronchiectasia or by lung abscess. So therefore, by itself, it's not the marker of cavitation disease like abscess. It means that patients having just more aggressive flora with higher risk of that. Pink sputum may be seen in patients with streptococcal, staphylococcal pneumonias. That is, again, sometimes will have blood streaks. A gravel may be seen in bronchiolithiasis with calcification of debris. It may be seen sometimes in patients with tuberculosis infection. Sometimes may be seen in fungal pneumonias. The so-called fungal bow. It's definitely not stone, but looking like stone, quite dense. And that may be the marker of calcification, calcified necrosis. Pink and frothy. Frothy means that there is significant loss of plasma, significant loss of proteins from patient's blood into the lumen of respiratory system. Therefore, that will be the hint for pulmonary edema. And if there will be a significant amount of blood from destroyed capillaries, it will be stained pink. So that's typical, for instance, for patients with left ventricular infarction. And that will be the marker of extremely severe state risk to patient's life that will require some immediate actions like potent diuretics, like tourniquets to patient's extremities, pulmonary ventilation that may save patient's life. In the case of cancers, it may be profuse, colorless, so-called bronchiuria. And bloody sputum may be seen in the case of bleeding, pulmonary bleeding, with quite a lot of causes for that. Sometimes it may be seen in pulmonary emboli, in the case of emboli to pulmonary artery. Fortunately, that's a rare event. Typically, it will be destruction of quite large blood vessel in patients with necrotic diseases, with cavitations like bronchiectasia, lung abscess, cavitating forms of tuberculosis. It's quite typical for late stage of pulmonary tumors, both primary, more likely, and less likely secondary. It may be seen sometimes in cardiac causes. Let's say it may be mitral valvular heart diseases. Sometimes it may be seen in patients with bleeding disorders. So patient will have absolutely normal lungs, normal heart, but it's just a problem in blood coagulation. How can we differentiate hemoptysis from hematemesis? Hematemesis is vomiting by blood. Hemoptysis is coughing by blood. First of all, please remember that if patient will cough out blood, it not always means that the patient is having cardiac or pulmonary disease. Patient may inhale blood that's coming from digestive system, and vice versa. Patient may swallow the blood that's coming from respiratory system. Therefore, if you are sure that it's strictly hematemesis, it not always means that patient is having a digestive disease like esophageal or stomach bleeding. And if you're sure that it's hemoptysis, not always it's respiratory disorder. In the typical case, hemoptysis is associated to mostly pulmonary or more rarely cardiac disease, hematemesis, disease of esophagus, stomach, or rarely duodenum. At appearance, it typically is frothy for hemoptysis because blood will be mixed with the other components into foam in hemoptysis, and there will be no foam formation if it's blood vomiting. The color will be typically bright. Blood, if it will be staying in the stomach, will be brown, will be almost black, that's coffee grounds, or dark red. But if it's esophageal bleeding, it will be quite red, not dark. Manifestation, blood may be mixed with pus. For hemoptysis, maybe mixed with food. You may pay attention to the pH of the blood, of the vomitus and sputum, and definitely there will be some some other associated symptoms. If it is bleeding interrespiratory system, there should be dyspnea. If it is vomiting is same pathological process, same mechanism as nausea. It's antiperistaltic movements of the stomach. So ask patient about presence of nausea before patient will produce blood. If before that patient had nausea, that is vomiting, that is hematemesis. If not, if it's difficult for patient to breathe, if it's frothy, then it's hemoptysis. Sorry. That is the marker of severe emphysema or any other causes for elevation of blood pressure, in the chest. You see puffy patient's face, you see puffy neck. There may be engorgement of superficial neck veins, of superficial jugular veins that are crossing sternocleidomastoidous muscle, and then very nicely they may be visualized almost in everybody. Sometimes there may be obvious engorgement of the deep internal jugular veins. That is the marker of elevation of pressure in the chest. Why that? That's another question. It may be the result of impaired function of the right ventricle, or it may be of respiratory origin due to presence of emphysema. That may be the primary background disease, or it may be associated to bronchial asthma, chronic obstructive pulmonary disease. Anyhow, please pay attention to that. If the patient's face will be looking like that, pay attention to diseases that may result in elevation of pressure in patient's chest. And by the way, don't forget about pleural effusion. It may be again of respiratory origin. It may be exudative pleurisy. It may be of cardiac origin. It may be bilateral hydrothorax. Again, in that case, there will be engorgement of veins and puffiness of patient's face. Finger clubbing. Finger clubbing is inspecific. We'll talk about finger clubbing when we'll talk about, let's say, liver cirrhosis. Any kind of disorder of supply of nutrients, of oxygen, may result in clubbing of fingers and clubbing of toes. But definitely it it will be most pronounced, it will be most obvious in patients with respiratory diseases. And of those, it will be most typical for patients with bronchiectasia, especially if bronchiectasia will be inborn, if it will be primary bronchiectasia in young patient, in a child, in adolescent. In that case, it will be well, early formation, they'll be obvious. So as far as I remember, I took that photo in a young patient. I think she was about the age of 30, and she had well, acquired bronchiectasia, but bronchiectasia developed very early in her life at the age of about 13. And therefore she had past history of more than 15 years of bronchiectasia, and she developed bronchiectasia at the age of about 25. So that will be the most typical case for development of well, clubbing of fingers. What may be the other well, causes for development of finger clubbing? Please remember that it will be even more pronounced, even more severe in patients with primary lung cancer. There are special syndromes named by authors like Pierre-Marie Bamberger syndrome, seen in patients with primary lung cancer. They'll develop and progress extremely rapidly once patient will develop primary cancer. Significantly more rarely it will be seen in metastatic cancer. Bronchiectasia is a typical non-neoplastic cause. Sometimes it may be seen in patients with cystic fibrosis, again, affection of lungs, deficiency of oxygen supply to distant portions of the body. It may be seen sometimes in chronic lung abscesses, in primary pulmonary fibrosis, and some other causes again that will impair well, blood supply to the fingertips of the patient. It may be cardiac, especially if patient will have congenital cardiac disease. Again, patient will live most of his or her life in ischemia, in hypoxia, and that will result in development of clubbing. Of gastrointestinal diseases, most typically it will be seen in liver cirrhosis. In that case, mostly due to lack of production of protein or albumins, and much more rarely it will be seen in inflammatory bowel diseases. While our clinic is specializing in inflammatory bowel diseases, it's one of our profiles, and extremely rarely we'll have patients with either UC, ulcerative colitis, or CD, Crohn's disease, that will have finger clubbing. So it's possible, but it's extremely rare. Sometimes it may be seen in patients with paralysis, paresis, hemiplegia. It's also described that patient may have clubbing. It's one of our patients with a mild cardiac disease. It's why it's interesting. Patient has very mild emphysema, never smoked. Patient had no lung cancer, no bronchiectasia, and developed spontaneous finger clubbing. That's why patient was interesting for us. So that may be idiopathic without any obvious cause. And that's TOEs of the same patient, much milder, but still you may notice that there is a mild clubbing of the TOEs. Yellow nail syndrome, a rare marker, but it may be seen in patients with inborn bronchiectasia. Sometimes it may be seen in pleurisy, in lymphoma, in sleep apnea, but what's most typical for inborn bronchiectasia. When we'll proceed from general part of examination to inspection of the chest, one of the basic features that we need to pay attention to will be the shape and type of the chest. That will be one of the typical questions at our examination. I'll ask you what will be the difference, and you should tell me that the basic difference is that type of the chest may be assessed only in patient with normal chest. So there will be subtypes according to types of body build, asthenic, normosthenic, hypersthenic. And if patient will have any deformities of the chest, you should not assess the type of the chest. So type is belonging only to the normal shape of the chest. And while shape is abnormal, type should not be evaluated. Pathological types, what will be the clinical significance of those? First of all, the barrel chest or emphysematous chest will be the marker of emphysema, will be the result of emphysema. That's why it is interesting for us, because it means if patient will have chest like those, it means that patient is having long-standing asthma complicated by emphysema, or vice versa, patients having emphysema most commonly complicated by obstruction. All other types like kypho-scoliotic chest, excavated chest, well, the pigeon-shaped chest, pectus carinatum, will be the causes for pulmonary disorders, will result in development of restrictive disorders. If patient chest is deformed, it means that patient will be unable to properly ventilate patient's lungs. And therefore, any deformity means well, insufficient ventilation of alveoli. So patient will either will have or will be predisposed for having restrictive disorders. Good. That's one of our patients. Patient had inborn cardiac disease. That's why patients having that scar on the chest. That's from childhood cardiac surgery. And patients having, well, more or less mild emphysema. You can see significant dilation in posterior anterior sides of the chest, but no significant protrusion of supra or subclavicular areas. So definitely there is emphysema, obvious emphysema. You may notice mild dilation of the superficial veins on the chest, but there may be much more severe changes with puffiness of lung apices above or under clavicles. This patient with Ankylosing spondylitis, it's photo taken from textbook. Deformity of the spine will result in inability to ventilate patient's alveoli. That's child with rickets, protrusion of the sternum. Again, in adult life, will result in improper ventilation, and patient will be predisposed for inflammatory diseases, will be predisposed for pulmonary fibrosis, will be predisposed if patient will have any additional disease for earlier and more severe development of respiratory failure. That is, again, photo of our patients. It's funnel-shaped chest. Well, impression into the sternum may be acquired, may be the result of trauma, damage, but in that patient, it's inborn. Just patient was born with the chest like that. Some deformity of ribs, deformity of the sternum. That again, well, in this certain patient result in just well predisposition for disease. Patient had, well, no pneumonias, no respiratory failure. But if patient, let's say, will start smoking, if patient will develop pneumonias, then definitely there will be much more severe progression of those. That's combination of kyphosis, well, side-wide, well, deformity of the spine, and kyphosis, forward deformity of the spine, resulting in development of severe restrictive disease. It's patient from Department of Pulmonology. Patient had significant well, issues in pulmonary ventilation. Same as this patient, paralytic chest. You may see atrophy of pectoral muscles, those atrophy of other muscles, trapezoid muscles, let's say, sternocleidomastoidous muscles, and definitely that predisposed patient for development of respiratory failure. Sometimes inspection of the chest may reveal some possible causes for secondary pulmonary changes. It may be either primary tumors of the lungs or the pleura, as this patient with mesothelioma of the pleura. Fortunately, in many cases, they will be small, but again, it will be difficult to diagnose at the early stage of mesothelioma. Sometimes you may get some help from CT, from ultrasound, but typically without pleuroscopy, without invasive examination, you'll be unable to diagnose the disease. Please remember about one of the most commonest cancers, is breast cancer, that may give secondaries into parenchyma of the lungs, into pleura, And unfortunately, in many cases, we skip examination of breathing glands. We don't do inspection, palpation of breathing glands, and sometimes the cause for secondary pulmonary changes may be hidden. We need to describe how patient is breathing. We need to describe external respiration of the patient. That may be done by different features, by different parameters. First and the most basic will be the assessment of the respiratory rate. If patient will have tachypnea, respiratory rate will be more than 20 per minute. In that case, definitely patient will have dyspnea. It's just a synonym as this dyspnea. You need to describe the amplitude of breathing, whether it's superficial or deep. You need to describe involvement of accessory respiratory muscles. You need to describe interrelation of the inspiratory and expiratory phases. Normally, exhalation is just slightly longer than inhalation. If it will be obviously longer, it's a marker of expiratory dyspnea. Same as involvement of expiratory accessory muscles. You need to describe any sounds that you'll hear during a patient's breathing at the distance, so presence or absence of wheezing. Again, for instance, if patient will exhale with breathing, it means that patients have an obstruction. It means that the bronchi will become more narrow during exhalation. And the last point that definitely will be important mostly for patients in the ICU will be the abnormal patterns of breathing, abnormal rhythms of breathing. First of all, it may be just for absence of breathing. It may be apnea, one of the markers of the clinical death. If patient will have no breathing, if patient will have no pulse on the carotid artery, and absence of central reflexes, corneal reflex, or absence of response of the irises to light. In that case, it means that patient is in the clinical death state. Bias respiration. It will be phasic, so there will be some episodes of breathing, and pauses, and patient will have apnea. So that will be irregular breathing with long periods of apnea. Chain stocks breathing will be some gradual increase and decrease intensity of breathing, again with the pauses, with the episodes of apnea. And Kussmaul's breathing, it will be sometimes fast, sometimes rare, but it will be deep and noisy. Phasic respiration, cyclic biots chain stocks respiration it will be typical for affection of the respiratory center. Will be typical for affection of the medulla oblongata. It may be seen in increased intracranial pressure. It may be seen in drug or alcohol toxicity. It may be sometimes seen in severe hypoxia of the brain or brain damage. Kussmaul's breathing is mostly toxic. It may be seen in metabolic acidosis most likely, or sometimes in toxic states. Well, after inspection of the chest, we need to proceed to palpation. Definitely don't forget that sometimes some features of general examination of the patient may be done within the palpation of the chest, like palpation of the lymph nodes, palpation of the skin, palpation of the breathing glands. But then we need to assess something that will be specific for respiratory system. We need to assess chest tenderness. So it means that we need to evaluate the ability of you to palpate chest properly or not. If patient will have, let's say, broken ribs or metastasis of the cancer into ribs, in that case, definitely the normal palpation or normal examination of the chest will be impossible. So that will be the first, the assessment of the ability to do the full-scale palpation. Second is rigidity of the chest, whether the chest is compressible or not. Typically, it will indicate some states that may result in restrictive syndrome, like sclerosing of patient's ribs or severe pulmonary fibrosis. Sometimes you may pay attention to some local swellings, areas of induration, pulsation, fluctuation that may be important from the point of view of, again, evaluation of the state of ribs, evaluation of the effusion in the pleural cavity if there be fluctuation sign, or some cardiac diseases that may have secondary manifestations from the respiratory system. You need to assess the degree and quality of chest expansion. Ask patient to breathe in, breathe out, and measure chest circumference. And by that, will helping you in the evaluation by the measuring tape. And one maybe of the most important features will be to assess the conduction of chest vibration. That will be the vocal fremitus. Vocal fremitus will evaluate the degree and presence of conduction of the vibration. Therefore, state of trachea, bronchi, pulmonary parenchyma, pleura will affect the presence of conduction and degree of conduction. If there will be block of respiratory tract, trachea, bronchi, patient will have significant decrease and local decrease of conduction. If patient will have a decreased density of the lungs, like in emphysema, there will be diffuse decrease in conduction of vocal fremitus. If there will be consolidation, there will be increase in conduction. It may be diffuse increase in fibrosis, or it may be local in cancers, in pneumonias, increase in conduction, and again, it will be extremely helpful in diagnosing of consolidation diseases. So therefore, vocal fremitus will significantly help you to understand what to do later on, which areas should be investigated more thoroughly by percussion and by auscultation. Well, that's how you should do a palpation of patient's apices. You should relax your fingertips. Typically, we use fingers for palpation, especially if we will assess tactile fremitus. Anyhow, there are different approaches. So in many textbooks, well, as far as I remember, it will be the British School of Physical Examination, American School. They use the edge of the palm. They apply that. That will better conduct vibration. We use fingertips and fingers that are more sensitive. Well, again, it's up to you and up to what you're adapted to do. So typically we use like that, and if you have practical exam prepediutics, better use your fingers. So first, palpation of patient's apices, the supraclavicular areas, then reposition your palms well down underneath clavicles, and you'll assess the upper portion of the lung fields, like that. And then you may apply only your left hand to patient's lower right lung and assess the conduction of the tactile fremitus to the lower portion of the right lung. We do not compare lung to the heart, and therefore your right hand will not be placed to patients on the left side of the chest. Same will be done at the lateral areas of patient's chest and at the back when you palpate again, suprascapular, interscapular, and subscapular areas. So some is all up. You need to position your palms at the three levels at the front, typically at the 2 points, 2 areas at the sides of patient's chest and at the 3 locations at the back of patient's chest. Then percussion. Percussion will be subdivided to, when should we will finish our class at 1:10, we have plenty of time. To comparative and topographic. And the basic point, what we compare the sound of comparative percussion to is to compare to normal sound. That is the most important. So comparative percussion in most of the cases means that we compare patient's chest to the normal healthy chest. Definitely we compare both sides, left to right. Definitely we compare superior areas to inferior areas of patients' lung fields. But most important for comparative percussion will be compared to normal chest so as to assess the features of the sound itself. Topographic percussion is for assessment of the borders of patient's lungs. When you'll do percussion, I will try to practice. It will be important for you to press the proximity finger as deep as possible to patient's chest. Strictly perpendicular strike. That there should be a very sharp strikes, a very short time of contact of plexus to proximity finger. And in that case, you'll get the sound from patient's chest, from patient's body. If there will be insufficient contact, there will be not perpendicular strike, but it will be rather oblique. In that case, it will be rather sound from your finger itself that will produce some kind of dull sound, bony sound, than the sound from patient's chest. Good. That's how percussion should be done. Well, strictly perpendicular and tightly pressing plexus. Typically, me personally is using the distal interphalangeal joint, or you may use the second phalanx of your finger, proximity finger. It should be tightly pressed into patient's chest. That's how it should be done. Absolutely relaxed wrist joint, strong plexus finger like a hammer, and relaxed sharp knocks over the proximity finger. For auscultation of the lungs, so we need to assess different features, different sounds that will be subdivided into the basic sounds, mostly vesicular and bronchial breathing, and added sounds. That will be the, again, most of the important of them will be the rails, pleural friction rub, and crepitation. Beside that, there will be some additional sounds that will be related to basic respiratory sounds and extra sounds. Point is that there will be different pattern, different approach for auscultation of patients' lungs while you're assessing the basic and respiratory and then the added respiratory sounds. In any case, definitely, patient should be relaxed. Better if patient will stand or sit. Patient should be naked and then should be exposed to the waist. Definitely should be warm, and then the patient should be protected from the external noise again, so that you'll hear sounds from the patient's chest, not from the outside. Pay attention that you should need to tightly press phanendoscope. There should be no extra sounds produced from rubbing of phanendoscope over the chest. Talking about differences, when we auscultate, when we assess the basic sounds, patient should breathe more or less normally, just slightly deeper than normal tidal breathing. Patient should breathe through the nose. That's for assessment of the basic sounds. If we try to assess added sounds, if we talk about assessment of the rails, about crepitation, pleural friction rub, patient should breathe deeper and through the mouth. That's a basic difference. Sites for auscultation of patient's lungs will be basically same as the sites for comparative percussion. So we assess patient's apices at the front. Well, moving down, we move mostly along the midclavicular line at the right side. For the left side of the chest, we'll move outside the cardiac dullness. We will move to the typically anterior axillary line. We assess lateral areas by the medial axillary lines, and at the back we auscultate in the apices, suprascapular areas, interscapular areas, and subscapular areas. Again, roughly speaking, it will be almost same sites, almost same areas as for comparative percussion. Well, according to our textbook, well, you should auscultate for 2-3 respiratory cycles, well, each side. Well, in practice, unfortunately, we have not enough time to auscultate for 2 or 3 respiratory cycles. Well, all sides, all of those shown here, and therefore, in many cases, in routine practice, we auscultate only for one cycle, well, all areas. But if there'll be something suspicious heard, well, in that case, definitely you have to auscultate for better, well, 3 cycles if you suspect that there may be changes in the basic sounds, or if there are some added sounds in the side. For basic or main respiratory sounds, there is vesicular and bronchial breathing that will have well, quite well, different clinical significance. Vesicular breathing is the sound produced by the pulmonary parenchyma. Sound produced by expansion of the alveoli during the inspiratory process and at the very beginning of the exhalation. So we can hear the sound during the all the way of the inspiration of the patient. At the very beginning of the exhalation, the 2/3 of exhalation will be silent. So to say that you are auscultating to the vesicular breathing, you need to watch how patient is breathing, watch well patient's chest expansion, and try to understand. If you see that patient is still exhaling and you already hear nothing, it means that that is the vesicular breathing. If you'll be able to hear the inspiration and all the way of exhalation, that may be well, slightly longer than the inspiratory phase. That is the bronchial breathing. Tracheal breathing is well, more or less equal inspiratory, expiratory well, components, phases, and will be quite loud in comparison to bronchial breathing. Tracheal breathing, bronchial breathing, basically is the same sound, but it will be heard slightly different because while one may be heard directly, if you auscultate patients, larynx patients, trachea, another will be auscultated through slight amount of the pulmonary parenchyma that may slightly cover patient's trachea and spine in the back, or well, sternum at the front, that again make the sound softer and milder. Bronchivesicular breathing, well, typically it's mixture of bronchial breathing and vesicular breathing. So that's something that is the resultant, the result of mixture of the sound coming from larynx and trachea and sound coming from alveoli. The point is that normally you should hear tracheal and or bronchial breathing only over the trachea and its bifurcation. Nowhere else except for manubrium sterni and the superior portion of the body of sternum, and up to interscapular space, nowhere else you should hear sound like that. If over the lung field, you'll hear either bronchivesicular breathing or bronchial breathing instead of vesicular, that is the pathological state. It means that patient's pulmonary parenchyma is conducting sound better than it should. Anyhow, let's start from the start. So vesicular breathing is soft, low in sound. Entire inspiratory phase is audible. The first third of expiratory phase is audible, and it should be heard over the whole lung fields. What may happen to vesicular breathing? There may be some physiological changes, well, extrapulmonary, that are quite obvious. So if patient is fat, obese, definitely in that case due to excess of subcutaneous fat, or it may be due to extreme thickness of chest muscles in sportsmen. There may be decrease in intensity of vesicular breathing. Or it may be enhanced again due to decreased thickness of the chest in asthenics and patients that are undernourished, and then patients with severe nutritional deficiency, with atrophy of muscles, with loss of a normal fat layer, you'll get enhanced physiological enhancement of physical breathing, just about absolutely normal sound of physical breathing like that, but it will be heard better than in typical, normal, so to say, healthy patient. There may be some enhancement of physical breathing after physical exercises. Bronchial breathing is sound produced in larynx and trachea. It should be heard only over the larynx and trachea with its bifurcation. So it should not be heard over the lung fields. So that will be the areas where bronchial breathing should be heard. Decrease in physical breathing. What may be the possible causes? First of all, it may be diffuse. You'll hear more or less, well, normal sound, but that is extremely weak, while patient is having no obesity and no overdevelopment of chest muscles. A patient may have obvious signs of emphysema that will be the barrel-shaped chest. That is pathologic decrease of physical breathing due to emphysema. There may be obstruction of bronchi, obstruction of trachea. In that case, definitely less air will come to alveoli, and patient will have a decrease in vesicular breathing. And third group of the causes will be the affection of alveoli themselves. It may be a tumor, it may be well, foreign body, it may be pneumonia, it may be well, edema, it may be atelectasis. But if there will be some loss of active parenchyma, or if parenchyma will be unable to be involved in ventilation normally, in that case, there will be local decrease of vesicular breathing. So once again, diffuse is for emphysema. Local is either block of respiratory tract, of bronchi, or affection of pulmonary parenchyma. Good, I think we'll yes, we discussed that already. Coagular breathing may be diffuse, may be seen all over the chest. And it's typical for patients in shivering, for instance, so when there is increase in body temperature. But it may be local. It means that there will be some kind of inconsistency of the entry of the air in the small bronchi or from small bronchi into pulmonary parenchyma. That may be seen in severe destruction bronchial wall, may be seen in patients with bronchiectasia, but it's most typical for severe loss of elasticity in patients with tuberculosis. Harsh breathing. Harsh breathing is difficult to describe. You need just to hear that. It means that first, there is slight elongation of the audible expiratory phase. So it will be closer to bronchial breathing from that point of view. And second, it will be more, well, intensive and literally more harsh in its pitch and its presentation. It will be formed when there will be more rapid jet of air will come into alveoli. That will happen if bronchi will become more narrow, and therefore there will be high velocity of the jet of the air that will enter alveoli. It will be seen in patients with either, well, bronchiolitis, inflammation, and therefore narrowing of small bronchi, or it may be due to compression of the small bronchi in patients with parenchymal pulmonary disease, when there will be some kind of interstitial changes, interstitial fibrosis, or interstitial edema. Bronchivesicular breathing, once again, it's not independent type of breathing. It's mixture. It means that there is well some components, some admixture of the bronchial breathing that will be mixed to normal vesicular breathing, and therefore patients typically is having some kind of mild consolidation changes around bronchi. Most commonly, it will be seen in patients with focal pneumonia, maybe early stage of cancer, or some well focal fibrotic changes. Pathological bronchial breathing, pathological bronchial respiration. What means pathological? There is only one point that differs bronchial respiration from normal bronchial respiration. That is location. If bronchial breathing will be heard not only over the trachea and its bifurcation, but somewhere else, that is pathological. And therefore, it means that your patient is having consolidation disease. Your patient is having pneumonia, your patient is having atelectasis, your patient is having some other states associated to increased conduction of the sounds. For instance, it may be seen in thick-walled cavities like cavern or lung abscess that may be combined in that case to amphoric breathing. Added sounds. Added sounds will be, sorry, Дорогой Александрович. Okay. Okay. Sorry, just will make a break for just a couple of minutes. I need just to fix the problem with another professor. Sorry. Our class, unfortunately, there are parallel lectures along with ours, and then I had to fix some technical problems. For added sounds, there are three basic groups that will represent some three basic components of respiratory system. We have rails for bronchi that may be dry or moist. We have crepitation, and we have pleural friction rub. What you see here is not quite recommended description of respiratory issues. I took that from one of the textbooks of internal diseases, but try not to use the term crackles. Once again, it's just my request as to teach you in propedeutics, because crackles means that you are unable to differentiate rails from crepitation. Rails, it will be the moist sound of bubbling produced in bronchi. Crepitation is something produced in alveoli. If you're unsure whether it's bronchial sound or sound from alveoli, then in that case we use crackles. But it means that differentiation is impossible. So it's not just about older term; it's the marker of our inability for differentiation. Rails should disappear after coughing. Crepitation will not. That is a basic marker indicating that whether it's literally secretion in the airways, or whether it's the problem in the pulmonary parenchyma, like pulmonary edema, or it's pneumonia, it's infection of the pulmonary tissue of the alveoli. Wheezes. Wheezes may be used. This term may be used for a distant sound that will be heard from patient's mouth without phonenoscope. Typically, we use dry rails or rhonchi when I talk about some kind of issues with the passage of the air through the bronchial lumen. So rhonchi or dry rails, that's typical term that may be used for description of changes in bronchial tree in patients with bronchitis, with inflammation, with excessive secretion, with compression of the bronchi or spasm of the bronchi. And pleural friction rub. Pleural friction rub is sound produced outside the lung, and that's how we're trying to differentiate that. It will be heard much better than rales or crepitation. It will be heard just well underneath your phanendoscope very, very clearly, not just more loud, but without any dullness, any well muting, any well muffiness of the sounds coming from inside of the respiratory system. But unfortunately, problem is that the pleural friction rub may be combined to other sounds. If patient will have pneumonia, patient will have crepitation, patient may have rales because of secondary bronchitis that will be mixed with pleural friction rub. What to do? Well, try to do something that will affect pleural only without affecting alveoli or bronchi. Press by a phanendoscope over patient's interspace. That will press the parietal pleura to the visceral pleura. Pleural friction rub will increase. Crepitation or rales will not increase. Ask patient to cough. If after coughing there will be change, that is a rale. If there will be no change, in that case, it's either crepitation or pleural friction rub. Ask patient to bend to the opposite side. Pleural friction rub will increase, rales crepitation not. Ask patient to bend to affected side. There will be decrease in pleural friction rub, other sounds will not be changed. Sometimes you may ask patient to close his or her mouth and nose, try to inflate and deflate the abdomen. We'll use abdominal muscles to push the diaphragm up and down. And in that case, again, there'll be no movement of the air, no rales, no crepitation, but there will be pleural friction rub if patient is having pleurisy in the lower portion of the lung fields. Good. Well, that's for rails. If there'll be just well narrowing of the bronchial system, spasm, edema, or a secretion of the viscous mucus, there will be dry rails. If there will be well some kind of fluid inside of respiratory system, that will be the moist rails. Moist rails will be heard more during the inspiratory phase, better during the inspiration. Dry rails better will be heard during the exhalation. Well, coughing will change rails somehow. Sometimes, well, coughing may increase rails, but typically there will be decrease in intensity of rails or disappearing of the rails after coughing. There will be some kind of redistribution of mucus through bronchial system, and typically rails will disappear. Even just well deep respiration will result in well some kind of well destruction of the fluid column in the bronchus, and that will result in decrease in rails. So for instance, you may start well auscultating your patient in the morning, patient with, let's say, with bronchial asthma, and you'll hear plenty of dry rails, maybe moist rails. Then you may visit your patient well at the daytime, and after patient will move, well, patient will walk, patient will have some even mild physical activity, there will be significant decrease in intensity of the rails. You may even notice that during the auscultation, when you just start auscultating patient with asthma, with the bronchitis, there will be plenty of rails, and at the end of auscultation of the patient, there will be significantly less amount of rails. Dry rails, the mechanism is spasm, typical for asthma, swelling of bronchial mucosa, swelling of the bronchial wall that will be typical for bronchitis, and viscous sputum, again, it's a rather obstructive asthmatic component. High-pitched rails will be typical for spasm of small bronchi. If there will be affection of the large bronchi, or if there will be some kind of mucus cords in between opposite bronchial walls, in that case, patient will develop low-pitched rails. And yes, if there will be dry areas and if there will be affection of the small bronchi, in that case, there will be harsh breathing. Moistures is the result of some kind of bubbling of the liquid component. It may be serum in patients with pulmonary edema, it may be blood, it may be mucus, it may be pus. Well, anything should be staying in small bronchi in the case of small bubbling rails, in medium or large bronchi if there'll be medium-sized bubbling rails, or in the cavitation like lung abscess, tuberculosis cava, and bronchiectasia, if we talk about coarse bubbling rails. So the term coarse bubbling rails is coined for cavitation syndrome. So if you will put down in the case record coarse bubbling rails, it means that you suspect presence of cavitation disease or diseases in your patient. Consonating rails or sometimes crackling rails. It may be the marker of consolidation over the pulmonary tissue that will surround bronchi. So it means that if there will be, for instance, area of pneumonia around the focus of the lung abscess or around bronchiectasia, or if there will be well, the area of pneumonia that will surround the focus of bronchitis, in that case, it will be much better conduction of the rails to the surface of the chest to an endoscope. And therefore, well, if you'll hear the sound of rails very clearly without being muffled, in that case, you'll put down the term consonating rails, and that may be the marker of well, ongoing pulmonary disease, parenchymal affection, parenchymal involvement. Sorry. Алло, да, Владимир Ильич. Я читаю лекцию сейчас, на кафедре, но я в Zoom, я читаю лекцию студентам с своей комнаты, да. Если можно, я закончу буквально через 15 минут. Можно? Да, хорошо. Спасибо, хорошо, Владимир Ильич. Sorry, this was head of department. We are trying to prepare the new English textbook for students in Pathologics. So hope that it will be ready maybe in 1 year. Good. Turning back to edit sounds. Crepitation. Crepitation in many cases will be difficult to differentiate from rails. That's why there is term crackles. But well, you should do your best to do that, because crepitation means that there is well, exudate or there is any fluid inside alveoli. So it means that there is another disease. So rails is for bronchitis, crepitation is for pneumonia. If your patient will have both moist rails and crepitation, means the patient is having both pneumonia and bronchitis. It's quite common situation. Only crepitation, just pneumonia without bronchitis. Only rails, just bronchitis. Sound may be very similar to rails in its pitch and its pattern. It will be heard best on the climax of the inspiration, when there will be just the maximum pressure in the airways and the alveoli. And then the very end of inspiratory phase, there will be crackling sound. That sound will not disappear after coughing, because coughing will only move the exudate in the lumen of the bronchi. The lumen of the alveoli will not be, or almost not be affected. It means that patients having pneumonia, typically lobar pneumonia, extremely rarely it may be heard in focal or bronchopneumonia. Sometimes it may be seen in patients with fibrosis of parenchyma that will surround alveoli, and around alveoli there will be some very stiff tissue that again will impair normal expansion of alveoli, and there will be normal entry of the air into the lumen of the pulmonary parenchyma. More rarely, it may be seen in patients with atelectasis, typically compression atelectasis. Again, the alveoli will be compressed, will be limited, and there will be not elastic, not smooth expansion of alveoli that breathing in. Sometimes it may be seen if there will be lung infarction, there will be blood inside affected portion of the pulmonary tissue, and that blood, the components of the destroyed apices, will prevent normal smooth expansion of the alveoli. Pleural friction rub, sound indicating unsmooth pleura, sound that may be seen sometimes in patients with just dry pleura with dehydration. Sometimes it may be seen in patients with metabolic issues when there will be crystals of urea in severe renal failure. Sometimes it may be seen in patients with tuberculosis, because tuberculosis, cancers, are peripheral diseases, and if there is pleural friction drop, it means that parenchymal disease will reach the surface of the pleura, and in that case, parietal pleura, in other cases, visceral pleura will be affected. Please pay attention that parietal pleura will have pain receptors, visceral pleura will not. But if they will be rubbing, typically a patient will have some more or less intensive pain in the site of pleurisy. That may be used as some kind of the extra hint, extra help for differentiation. In the site of pleural friction rub, there will be some degree of pain. Pain as pleural friction rub will be more intensive at deep breathing, at coughing. If you press in the side of pleural friction rub, again, that will be painful or uncomfortable for the patient. And please remember that in many cases, you may feel the pleural friction rub by your fingers. It will be something like tactile fremitus, but patient will say nothing. You still feel the vibration of the rubbing of the pleura in the site of pleural friction rub. So in contrast to crepitation, contrast to rails, pleural friction rub is palpable sound. And bronchophony. Bronchophony is auscultatory equivalent to tactile fremitus. If tactile fremitus will be, well, the sign that will be listed by palpation of the chest, bronchophony will be evaluated by phonenoscope. The difference is that bronchophony will require whispering sound, and therefore sometimes if it will be well enhanced, we call that whispering bronchophony or whispering pictorial acqui. That is some kind of benefit in comparison to tactile fremitus. Tactile fremitus will require patient's voice, patient's larynx, patient's vocal cords. And well, all of our patients will have different pitch of the voice. Males typically will have lower pitch that's conducted better. Young patients, females will have high pitch of the voice that's conducted more poorly. While bronchophony will require whispering that is not sound. It's a sound that will be produced by patient's mouth, but patient's tongue, not involving larynx, not involving different pitch of the voice. That's the benefit. So patient should use loud whispering. Patient typically will say 55, and you assess again in the same sites as for other allocation for auscultation, trying to understand what patient is saying. If you'll be able to understand that the patient is saying 55 without whispering like 55, in that case, it means that the conduction of the sound is increased. If you'll be unable to understand what patient is saying, just some kind of the distant echoing, you'll be able to understand the patient is saying something, but you'll be unable to recognize the patient's phrase. That's normal, indicating normal density of patient's parenchyma. The causes for that will be, well, any consolidating disease. It may be pneumonia, it may be compression atelectasis, it may be pneumofibrosis. Good. Well, that is all for today. I have, well, nothing to tell you. And if you have any questions, any difficulties, please tell me, well, ask me. Let's discuss if you have some questions. No questions? Yes? Next topic will be devoted to repetition review of examination of cardiovascular system. So again, we will talk about patient symptoms, talk about the differentiation of angina-like pain, of angina pectoris from other cardiac but non-coronary pain, and about all other basic steps in examination. We'll talk about inspection of the chest, inspection, palpation of the apex beat, right ventricular heave, percussion of the cardiac dullness, relative and absolute, and we'll talk about cardiac sounds and murmurs. That will be, well, according to timetable, I have next class on Thursday. So it should be Thursday, 11:35. Well, if my timetable is correct, that will be on Thursday. It will be on the Thursday. On Wednesdays, we have lectures, but the first lecture is scheduled on 9th of September. So no lecture tomorrow. First lecture should be on the 9th, so in the next week, like that. Yes, lecture will be next week on Wednesday at 15:45. Our next class will be in 2 days on Thursday at 11:35. Well, actually, you may use my slides that I just, well, posted in my Google class for the previous semester, because it's repetition for cardiovascular system, nothing new. For next classes, I'll try to download PDF of slides and for gastroenterology. Okay. I try to do that. It's quite difficult because, well, actually, I, well, prepared no slides for the classes, but I'll try to do that. Okay. Goodbye.
Professor,
Yes. Yes.
beg your
Yes.
pardon, but I'm 79. But you know the classes have been changed, so there's a lot of confusing between the students. Can I attend the classes with you?
The point, well, first, yes, definitely may attend my classes, but you need to discuss that with the department, with the chair that you belong to. Because, well, it's not difficult for me and quite pleasant for me if there'll be extra students listening to my classes and lectures. But, well, we have, well, officially only groups from 66 to 75.
Yeah,
Well, that belongs to our department, that is Vasilenko Clinic.
yeah.
You may have issues with your teachers and the department that, well, you have your official classes with. So if there'll be no objections from them, well, I'm glad. But you need to talk to your teachers, well, that's something not normal. Well, that you attend classes at the different department. For me, it's good. But you have to settle that with the dean's office or, well, department that you have classes in.
Okay. Thank you so much, Professor.
So unfortunately, I cannot help you. Well, have timetable only for our department. I know which groups belong to us, but I
Yes.
don't know where you should study propedeutics. Well, typically we share students with Tarev's clinics, with the occupational medicine clinic that is in the Rostelium Street. There are a couple of groups that should study in person. Several groups that should have their classes distantly. That's group 79, your group. But I don't know where.
That's why, because we only, I think, 4 students or 5, and there's been changing. So I think maybe I'm solo or someone student with me. Because of the coronavirus, it's I don't know. It's we all like the roller coaster here.
Are you studying in Moscow or in another
No,
country?
abroad, in my country. I'm in Kuwait.
I see. Well, on my side, no objections if you attend my classes. Well, I can prove that you attended them again.
Yeah.
So you have the Google form, and it's to prove that you attended classes. But
Yes.
it's better that you'll find out your proper teaching and the department with which you'll have your classes with. How to do that? Well, no idea, because I know nobody from Tarev's clinics, and I cannot send that information there. Try to do that, but we have only computer and then only our web page.
Yes. Thank you so much.
Okay, welcome. 77 group is not belong to department to our department, so only up to 75. Mm, 77 should have classes in person. So if you are in Moscow, if you pass 2 weeks quarantine, you have to attend your classes in the clinic, because you are I'm trying to share my screen. Um, can you see that's table in the board? So that is the table that was sent to us by the dean's office. That's a second year of study. That's not yours. A third year of study. So that is only groups for our department from 66 to 75, and 76 and 79 distant form of education. Очное means in person. That is for 77th group, 78 and 80. No idea where to. If I'll find it out, I'll try just to type that in my Google class, share that information. But most likely it should be Tarev's clinics. Okay. If there are no other questions, should
Hello.
yes.
Hello, Professor. I have questions.
Yes.
Today is
Yes.
a class for the 75 or for from the 66
Well,
to
officially,
75.
I should have a class only with groups 74 and 75.
But today we in the 67 we have the internet disease at 8 at 8 p.m. but 8 a.m. But there are no anything information in our website. So I joined this class. So it means I don't
if
have.
it's convenient for you, well, no issues. Well, if you are from group from 66 to 75, it's quite okay if you attend my classes. No problems. Well, because
No
I am
problem.
in charge. I am the head of English speaking department of our
Yeah.
department. So it's absolutely okay. But if you belong to another department, there may be issues, and you have to settle them with the dean's office. From
Okay,
66
understand.
to
Thank you.
75, no problems. So you're
No problem.
welcome.
Okay.
You may attend my classes.
Okay. Thank you, Professor. Have a nice day. Bye.
Thank you. Thank you. Goodbye.
Excuse me, Professor.
Yes.
Actually, I'm staying abroad in India, and my group number changed from 67 to 77. But the 77 group is in person, not online. So
Yes, 77 group is in person. Well, the point is that I'm not your dean. I'm trying to find it out, but try it maybe to use the web page of the university. Write your dean, because it's not up to me. I have no right to mess with other students. I tried to call the dean. I tried to call Professor Morozov. Maybe that will help, but actually, maybe it will be more convenient if you'll just type names of the students with the issues. For instance, if you dedicated for personal classes and you're not in Russia, not in Moscow, in that case, what to do? So please, type that in WhatsApp if you have my phone number, or in the Google Class. I try to prepare the list of students with some issues, and after that I'll call Professor Morozov while trying to settle that.
Can I get your WhatsApp number?
It's 916, +7 for Russia, 916 624
624
58
58.
69.
Okay.
But no phone calls, no calls in the WhatsApp, only for texting.
Yes, yes. Okay.
Because I will not pick the phone. I have plenty of my patients,
Yeah.
and then other persons who are calling me. Only for WhatsApp messages.
Thank you so much.
Or better use Google Class
Yeah.
for that. If there'll be no response for me, just text in WhatsApp.
Okay. Thank you. Thank you so much.
Okay. Goodbye.
Goodbye.
Goodbye. Well, see you on Thursday.
Yes.
Bye.